Good morning, welcome, and thank you so much for joining us today. My name is Coral Owen. I'm the Professional Development Coordinator for the Military Families Learning Network. In case you're joining us for the first time, I'd like to give you a brief tour of our webinar platform so you can find your way around. Hopefully you're currently able to view the slides we're sharing. If you can't see them or have any other technical difficulties today, you can send us a tech support request via email to milfamln@gmail.com. We'll place this email address in the chat pod momentarily for your convenience. As some of you have already done, we do look forward to having you join us in the chat pod today for conversation, for questions, as well as hellos. To embed the chat so you don't miss any links or conversation today, simply place your cursor over the shared slides. If you move it towards the bottom of your screen, you should see a toolbar pop up, and then from there you can just simply select the chat bubble icon. When typing your comments and questions, please do be sure to select the Everyone Response option from the drop-down menu. Right above where it says Type Message here is where you can switch that out. This just ensures everyone that's on today's webinar can view those comments and questions as they come through the chat pod. We'll also be covering evaluation and continuing education information at the end of today's session. I'd also like to note that these slides that we'll be working through today, as well as a list of resources, are available for download on our event page if you'd like to go over there and check those out. Closed captioning is available for today's webinar. Additionally, if you need a transcript of today's session, you can simply email us at milfamln@gmail.com, and we'll be happy to send that over to you. The Military Families Learning Network is part of a DoD-USDA partnership for military families, and our passion is to connect military family service providers and cooperative extension professionals to research and to each other through innovative online programming. It's my pleasure now to turn things over to my colleague, Kaylin Goebel. She's the co-PI for the MFLN Family Development Team, and she'll be introducing today's presenters. Kaylin?
Hello, everyone, and thank you so much for joining us. Whether you're joining us live or viewing this session at a later date, we are glad that you could join us for this webinar today. Our SBCY series has also been a collaboration with the National Center on the Sexual Behavior of Youth team. So we would like to thank Dr. Jane Slofsky and her team over at NCSBY for their work on this series. And this is also based upon work supported by the Office of Juvenile Justice and Delinquency Prevention, Office of Justice Programs, and the U.S. Department of Justice. So we just want to thank all of our colleagues over at the DoD, OJJDP, and OJP, and DOJ for their work and collaboration on this presentation, as well as our greater SBCY, Sexual Behavior in Children and Youth series that continues to evolve and will continue to evolve later this year. For today's session, we are happy to be joined by Amanda Ruzicka and Luciana Assini-Mayton. Amanda is a Senior Research Associate in the Department of Mental Health and the Director of Research Operations at the Moore Center for the Prevention of Child Sexual Abuse, both housed within the Johns Hopkins Bloomberg School of Public Health. Her research primarily focuses on the development and evaluation of child sexual abuse prevention interventions. She also serves as a co-developer of child sexual abuse prevention interventions. Dr. Luciana Assini-Mayton is an assistant scientist at the Moore Center for the Prevention of Child Sexual Abuse at the Johns Hopkins Bloomberg School of Public Health as well in the Department of Mental Health. Her research is primarily concentrated on the development and evaluations of strategies to prevent children from being impacted by sexual abuse. At this time, I am happy to turn things over to both of them to begin today's presentation. And just one final note, we will be covering continuing education credit and information at the end. So if you're hoping to obtain CE credit for today's session, please stay tuned till the very end of today's session, in which Coral and I will be covering that. And as you see, Jason, my colleague, will be posting helpful links as well while Amanda and Luciana present today. So those will be in the chat pod, and you can keep up with those as they present and mention some resources to come. Thank you all.
Hi, everyone. Thank you for joining us today. Our webinar today is going to focus on preventing the onset of youth problem sexual behaviors. And just to give you a sense of the topics that we'll cover today, specifically, Luciana and I are going to review the terms problem sexual behavior and child sexual abuse and discuss how both are preventable public health problems. We will introduce our prevention intervention called Responsible Behavior with Younger Children and share a bit about the curriculum as well as our preliminary findings from a pilot study of the program. Then we will share an adaptation of RBYC we are working on for teens with intellectual and developmental disabilities. And to close out, we will conclude with next steps for our interventions and some time for questions. So for the purposes of this presentation, I just wanted to briefly review the definitions of problem sexual behaviors, or PSB, as defined by the National Center on the Sexual Behavior of Children and Youth, and also the Center for Disease Control and Prevention's definition of child sexual abuse, or CSA. So problem sexual behaviors refer to behaviors initiated by children and youth under the age of 18 that involve sexual body parts in a manner that deviates from normative or typical sexual behavior and are developmentally inappropriate and or potentially harmful to the individual initiating the behavior or to others as well. Whereas child sexual abuse is the involvement of a child in sexual activity that violates the laws and or social taboos of society, and that he or she does not fully comprehend, does not consent to, or is unable to provide informed consent to, or is not developmentally prepared for and cannot provide consent to. So as you can see, there's quite a bit of overlap in these two definitions, but for the purpose of this presentation, we will distinguish the two by using problem sexual behavior, or PSB, when referring to youth-initiated behaviors, and using child sexual abuse, or CSA, when referring to adult-initiated behaviors.
Thank you, Amanda. Hi, everyone. It's a pleasure to be here speaking with you today. I wanted to start by situating our work within the public health approach to violence prevention. And within this title, I wanted to draw your attention to the term public health. When we enter in the space of public health, we are going to start to shift our focus centered primarily on individuals and start to think about what are the strategies like educational programs, changes in policies that can reduce vulnerabilities and increase protective factors, and therefore can have an impact on a whole group or a whole subset of a population at the same time. So when we start to think about a problem from a public health lens, we are thinking about strategies that can protect a whole subset of a population. And this is what we do at the Moore Center for the Prevention of Child Sexual Abuse. The public health approach to violence prevention follows 4 main steps. First is to define the problem. In this case, our main focus is the prevention of youth problem sexual behavior, with a particular focus on behaviors that are directed towards younger children and also peers. We will begin our work by understanding what is the scope of the problem, what is the prevalence, where does it happen? And the work here may be as well doing this research that characterizes the problem. In the second step, we are going to identify vulnerabilities and protective factors. We are going to understand what are the factors that increases the likelihood that a child or a teen of engaging in problem sexual behavior, and what are the factors that decrease the likelihood of such type of behavior. And these vulnerabilities and protective factors are going to be the main focus of preventive strategies informed by a public health approach. The third step is informed by steps 1 and 2 and involves the development and testing of preventive strategies. And finally, the 4th step involves the dissemination of evidence-based programs, given that feasibility and efficacy were already established based on research. So let's begin by defining the problem, and let's start first by looking at what crime data tells us. Crime data shows that youth commit about 35% of sex crimes against children under the age of 18. Even though youth accounts for a sizable proportion of all reports made to the police, their recidivism rate is very low. In 2016, Michael Caldwell published a meta-analysis on the topic and found a recidivism rate of just 2.75%. And this is what you can see on this figure on the right of your screen. The high rate of desistance might also suggest that the problem sexual behavior towards younger children and peers are also preventable. Crime data also shows us that the peak age for problem sexual behavior towards other children is age 14, which may indicate to us that early teenage years can be an adequate time point to prevent youth problem sexual behaviors. Now let's look at another source of data that's from survey with the general population of children. This survey data shows a larger prevalence of problem sexual behavior towards younger children and teens as compared to crime data, which is already expected, given that crime data only reflects what is known by authorities. And in these data, teen problem sexual behavior represents 70% of all harmful sexual behavior with children under the age of 18. And if we go a little bit further and we break down this number, about 50% of teen problem sexual behavior is towards children ages 0 to 13. And the other half is towards children 14 to 17, and most likely their peers. The takeaway here is that these two types of data show that youth engage in a large proportion of problem sexual behavior towards younger children and other peers. And once they are caught engaging in these behaviors, they tend to not do it again. Therefore, we believe that with the right tools, we should be able to prevent this in the first place. In order to determine the components of a prevention intervention, we identify in the literature the dynamic vulnerability and protective factors associated with the onset of problem sexual behavior in teens. And by dynamic factors, we mean here those vulnerability and protective factors that can possibly change. We identify that low knowledge about sex, curiosity, impulsivity, and inadequate adult supervision are all factors associated with problem sexual behavior in teens. Some research with post-adjudicated youth found that empathic responding was associated with low recidivist rates for problem sexual behavior directed towards others. So in alignment with step 3 of the public health model for violence prevention, we made sure to address these vulnerabilities and protective factors in our intervention. When we do consider prevention, there is still a heavy focus on victimization prevention and educating children the so-called 3 R's. These 3 R's involve recognizing potentially harmful situations, resisting harmful behaviors, and reporting previous or ongoing problem sexual behaviors by another child under the age of 18 or child sexual abuse by adult. Some studies that have evaluated these programs identify that there is an increase in disclosure of victimization, but there is a lack of strong evidence that these programs prevent victimization in the first place. Disclosure is an outcome extremely important, particularly followed by an appropriate and effective response. However, it's important to know the limitations of victim-focused educational programs as it pertains to primary prevention. These educational programs might also be costly to implement, and while they have a value in increasing disclosure, the issue here relates to the fact of posing a heavy focus on children to defend themselves, while we pose little focus on approaches to prevent the initiation of harmful behavior by teens, which is the main focus of our presentation today, or to prevent the sexual abuse initiated by adults. We wanted to use this diagram to briefly situate where our intervention falls within the mental health intervention program spectrum. So a little bit of a background. In 1994, the Institute of Medicine published this figure, and one of the main goals was to differentiate between prevention, treatment, and maintenance, as oftentimes what we call prevention is not truly preventing harm from happening in the first place. And oftentimes you probably saw these three terms are equated to primary prevention, secondary prevention, and tertiary prevention. So they use here the word prevention only to designate an intervention or a program that will address an issue that has not yet started. And the terms universal, selective, and indicated within the prevention spectrum will express the level of risk or the level of vulnerability for experiencing a certain outcome. So our program falls within that first step within universal prevention, meaning that is a program designed to all teens in 6th and 7th grades without any particularly higher level of vulnerability for engaging in problem sexual behavior. Why we chose to develop our program, RBYC, as a universal prevention program? First, most teens who engage in problem sexual behaviors have no prior adjudications. As we could see in a previous slide, also the recidivism rate is very low. Teens who engage in problem sexual behaviors often do so in common everyday situations. These behaviors are also often a result of a lack of knowledge. Male and female teens may not be participating in or engaging in problem sexual behavior, but they might be impacted by them as bystanders. And finally, to have a selective or indicated approach might be difficult and stigmatizing for the teens participating in the intervention. In addition to understanding the characteristics of the problem and the vulnerability and protective factors, the development of our program was also informed by other evidence-based universal prevention programs designed for teens to find best ideas on best practices for our intervention. So we won't go into these programs during this presentation, but here are just two of the programs we reference when searching for best practices. One is Shifting Boundaries, which is an intervention designed to reduce dating violence and sexual harassment among middle school students. And the second one is Safe Dates, which is a program for middle and high school students designed to stop or prevent the initiation of dating violence. Specifically, some of the best practices RBYC is designed to have includes content continuity between sessions, parent-facilitated activities. Extensive research highlights the significant role parents play in their children's sexual development. We also have a multi-dosage program with 8 sessions, and we are trying to balance and understand what is the minimum number of sessions we need to have to achieve our intended results so we can maximize visibility. Our sessions are also designed for mixed gender groups, and we also use mixed educational strategies to maximize the difference in learning styles that students have. In particularly, we use behavioral skill practice such as role plays, which has been shown an effective learning tool in other preventive interventions. I will pass the word now back to Amanda, who will present to you the RBYC curriculum.
Thank you, Luciana. Okay, so on to our intervention. As Luciana mentioned, we developed a universal prevention intervention, and our intervention is a school-based prevention program. It targets teens in 6th and 7th grades and is called Responsible Behavior with Younger Children, or RBYC for short. The overall goal of RBYC is to improve students' knowledge and skills around problem sexual behaviors, as well as child sexual abuse, and how to prevent or intervene to keep themselves and others safe. The primary aim of RBYC and what sets RBYC apart from many other prevention programs is its focus on preventing teen problem sexual behaviors directed towards younger children. The secondary aim of RBYC is to also prevent teen problem sexual behaviors directed towards peers. And the program also addresses the prevention of child sexual abuse of adults towards both teens and young children. Our team was awarded a 2-year exploratory developmental grant from the National Institute of Child Health and Human Development, housed within the National Institutes of Health, to support the development and initial pilot testing of this curriculum. The RBYC curriculum has been designed in collaboration with Dr. Elizabeth Letourneau from the Moore Center for the Prevention of Child Sexual Abuse, housed within Johns Hopkins Bloomberg School of Public Health, Dr. Cindy Schaefer from the University of Maryland, and Catherine Bradshaw from the University of Virginia. The RBYC curriculum, as I mentioned, is designed for 6th and 7th graders in order to provide them with knowledge and skills before they reach that age that Luciana referred to of 14, that some research has shown is the peak age that teens tend to engage in problem sexual behaviors. And the hope is that we can provide these teens with knowledge and skills before they reach that age in order to prevent their engagement in these behaviors. Currently, the curriculum consists of an introduction and conclusion to the program, as well as 8 core interactive and discussion-based sessions that last about 45 minutes each. RBYC has been designed as both a standalone intervention or for integration with other violence prevention, health education, or sexual education classes. The curriculum is designed to be administered by teachers or other youth-serving professionals after relatively brief training and in diverse school and non-school contexts. RBYC is also designed to be implemented on either a weekly or biweekly basis. Now, the RBYC curriculum is not solely focused on teaching teens how to choose behaviors that will help to protect themselves and others against problem sexual behavior. When developing RBYC, we worked to take the responsibility off of teens so that in order to do so, we also share program-specific information and helpful resources with caregiving adults who can support teens in the program as well as beyond. Because of the sensitivity of the topics covered in the curriculum, we incorporate a trauma-informed approach throughout RBYC using the 4 R's: realize, recognize, respond, and resist. Individuals who implement RBYC are trained to realize that students in the class may have experienced trauma and how these experiences may impact them throughout the program as well as beyond. We teach them ways to recognize the signs of trauma and have a protocol that we put together with the school personnel's input about how to best respond to disclosures or suspicions of trauma and to work to support students in ways that will not re-traumatize them. When building the RBYC curriculum, we structured each session in such a way that students have an outline at the beginning about what will be covered that day, and also an outline at the end of each session about what will be covered the following session. We do this to allow students the ability to reach out for support or to ask questions about the session that's coming up. We also provide students with resources each time our team meets with them or the program is implemented. These resources are designed per school to highlight resources for them within their school community, within their local community, and nationally, and include both in-person and anonymous ways of reaching out for support. The resource sheet also informs them about things like limits to confidentiality, so that if they choose to reach out for support, they can make an informed decision about what information they might choose to share or where they would like to seek support. Caregiving adults are also provided with these resources, a schedule and reminders about when RBYC will be implemented, and information on what topics the curriculum covers so that they can also be better prepared to support students who may reach out for help. As Luciana mentioned, we know that parents and caregivers play a significant role in their children's sexual development. And so throughout the curriculum, we have dispersed 4 take-home family activities. And you can see these in purple, labeled with the sessions that they align with. The family activities are provided to students as a handout to take home. And each handout shares important information about what was covered in class, resources, and then suggested discussions that students can have with a parent or other caregiver that relates to the material they've been learning. Specifically, the discussions are designed to promote parental awareness of factors that may increase vulnerability for problem sexual behavior or child sexual abuse, such as low parental monitoring. They aim to encourage parent-child communication about problem sexual behavior and child sexual abuse, and to establish clear family rules against sex with children. Each family activity is designed to last about 10 to 15 minutes, so we want to keep them brief. And we also include suggestions for families about how to fit these brief conversations into busy schedules. So things like, discuss certain points when you stop at a red light in the car, for instance. And as you can see in the session titles, we focus on both problem sexual behavior and child sexual abuse throughout the program. We do this because teens are in the unique situation where they may mistakenly engage in problem sexual behavior with a younger child or peer, at the same time that they are also at risk of being victimized themselves. Therefore, RBYC sessions stress throughout that sexual behaviors between adults and teens are harmful and illegal, and provide examples of how the knowledge and tools in each session can be applied to positively navigate different situations where the students could be at risk of engaging in problem behaviors, of being victimized, or may be a bystander to someone else at risk of being harmed. So now I'm going to share some details and sample activities from each of our 8 core RBYC sessions. In the first, we focus on introducing the program, defining important terms, and really get into the developmental differences between teens and younger children. During the session, we focus on how to be aware of the differences between teens and younger children, and how younger children have different abilities when it comes to their knowledge, their skills, their verbal and nonverbal communication, their self-control, and their emotion regulation. Students are asked to discuss the younger children in their lives and how interacting with them can be fun, but it can also be frustrating at times. We found that by easing students in with some of these discussions and relating to their own personal experiences helped the students feel more comfortable participating, and also added some humor to the class as well, as many of them had some funny stories to share. Another activity during this session are developmental differences role plays. And I'll share an example of one of these, which is a 3-year-old boy is at a sports store with his parent. He wants his parent to buy him an NFL football jersey that costs $100. The parent says, "No, that's too expensive." The boy is very disappointed and upset. So after hearing this role play, students act it out and then discuss how the 3-year-old might handle this situation compared to how a teen might handle this type of situation. And students seem to have an easy time highlighting how a 3-year-old might throw him or herself down on the floor and scream and yell, while a teen might certainly express their frustration, but would never roll around on the floor of a store, for example. These role plays help students to understand how developmental differences may explain differences in younger children's behavior compared to that as teens. The focus of session 2 is on learning to take the perspective of younger children in common everyday situations and learning how to have empathy towards younger children. Students learn about how younger children tend to look up to teens and seek their attention and approval. They learn how the behaviors that teens have towards younger children can either be rewarding when they treat them well or harmful when teens do something hurtful. In class, students talk through examples of teens interacting with younger children and discuss what emotions students think a younger child might be experiencing in various situations. And we call this standing in someone else's shoes. Students then create responsible teen responses to the younger children in these situations. And one of the goals of this activity is to show teens how they can be helpful to children when they have the opportunity to, and how to identify these opportunities. During session 3, we focus on the definition and importance of consent and why children can never provide consent. This session also introduces what problem sexual behaviors and child sexual abuse are and the impacts that they can have on children who experience these behaviors. There's a video that we use to help add some humor to this discussion and make the topic of consent a little easier to talk about, especially since this is the very first session where we start talking about problem sexual behavior and child sexual abuse. So we were talking in the earlier sessions in more general terms and talking about everyday situations. So I'm sure many of you have seen the Consent ST video by Blue Seat Studios. And if you haven't, please check it out. The link is available on the events page. But the main idea of this video is that the video equates sex with a cup of tea, and it walks through various situations to illustrate how inappropriate it would be to forcefully serve someone a cup of tea when they are passed out or they've said no, for example, versus serving someone a cup of tea when they actively say yes. And so this was one of the favorite parts of the curriculum for students, and we would refer, as we talked about consent throughout the rest of the program, back to this video and drawing the similarities between the cup of tea and the difficult to talk about consent really helped them to more easily discuss this as we followed through the rest of the program. In session 4, we described specific behaviors that constitute problem sexual behaviors, as well as behaviors that could be potentially harmful, but not necessarily to the level of our definition of problem sexual behaviors. And so we refer to those as just harmful or inappropriate behaviors. And then also responsible behaviors. We present this information as an activity where students read a card with a behavior. And an example of that is a teen is watching TV with their 6-year-old neighbor. The teen reaches over and touches the child's private parts while the child is watching TV. So after the behavioral card is read, the class is asked to determine if the teen's behavior would fit into one of 3 categories. Category 1 being that the behavior was a problem sexual behavior. Category 2, the behavior was an inappropriate or potentially harmful behavior. And category 3, that the behavior was an example of a responsible behavior. Then the class engages in discussions about what each person thinks and why. And then if it is in category 1 or 2, so it's either a problem sexual behavior or a potentially harmful behavior, they talk about ways that the teen could have behaved differently in the situation to demonstrate responsible behaviors. And in this activity, we purposefully include cards with responsible behaviors to help demonstrate everyday situations where teens could practice making responsible decisions with younger children. So an example of one of those responsible behavior cards is a younger child walked into the room when a teen was watching a movie that depicted some sexual behavior between adults. The teen changed the movie to something that was appropriate for the child to watch too. So as we all know, there are many misconceptions related to problem sexual abuse and child sexual abuse. And some of those surround what behaviors are considered problem sexual abuse or child sexual abuse, and why someone, whether it be a teen or an adult, might engage in these behaviors with a child. Session 5 focuses on overcoming these myths and misconceptions and clarifying who might be likely to engage in problem sexual behavior or child sexual abuse, the reasons why they might do so, and the legal consequences of sexual behavior with a child. Since our pilot study, which Luciana will talk about in just a bit, took place in Maryland, we also taught students about Maryland's laws around problem sexual behaviors and child sexual abuse, so that they were aware of the local legal consequences that both adults and even teens can face. As an activity for this session, we asked all the students to stand up in a line around the room and did an activity called Cross the Line. In this activity, we read them statements about problem sexual abuse, problem sexual behaviors, and child sexual abuse, and asked them to take a step forward if they thought the statement was true, or take a step backwards if they thought the statement was false. And it was really interesting to see which questions students answered correctly and which ones were incorrect and caused a lot of debate within the classroom. And the statement that sparked the most debate was actually age 14 is the peak year for teens to be involved in a problem sexual behavior incident. Students were really surprised that a 14-year-old teen could engage in these behaviors and harm a child in this way. So we explained this concept to students and equated it with learning how to drive. So when teens first learn to drive is when they are most vulnerable to making the most mistakes, because they still have a lot to learn. As they get older, they learn and become better drivers. They have more practice. This is the same with sex and consent. When teens are young, they may not know much about sex and consent and what are appropriate or inappropriate behaviors. And that's where RBYC comes in, to help them learn this important information and these skills to help make better choices and have better behaviors to avoid problem sexual behaviors. We also sent these items home with the students as one of their family activities so that they could test out their parent or caregiver. And this was probably their favorite family activity. And they came back laughing about sharing which items parents got right or wrong versus what they got right or wrong. In session 6, we focus on risk factors for problem sexual behaviors and talk through ways that students can change these factors to avoid problem sexual behaviors. So we present these factors in 3 different categories: as child factors, situational factors, and personal factors. And so when we talk about child factors, we talk about factors related to the child and their behavior, things like curiosity, for example. When we talk about situational factors, we're talking about aspects of a particular situation that might make harmful or inappropriate behaviors more likely to occur, such as a lack of adult supervision. And when we talk about personal factors, we talk about factors about a particular person that may increase their vulnerability of harming a child, such as bad judgment or acting on sexual feelings when a child is around. In class, the students are presented with scenarios and had to answer the question, what would you do? One example of these scenarios is you and your friends are watching a movie and your friend's younger sister comes down with no clothes on. She says she can't get her clothes on. What would you do? And it was really great to see students walk through these role plays and discuss what the teen could do to choose a responsible behavior. So they would say things like the teen should walk away and get out of the room. But a lot of the students also took the time to add in ways to help the child as well. And so they would say things like, tell the child to put on a towel or robe and then come ask for help. And so that was really encouraging to see that not only were they trying to avoid a negative behavior and choose a responsible behavior, but they were also taking that a step further to take the opportunity to help the child. Session 7 applies the skills that we learned throughout earlier sessions to identify, understand, and respond to problem sexual behaviors with peers. We also include information in this session on safe adults, and we have students complete an exercise where they identify safe adults that they can go to for various concerns in their life. So basically, we wanted them to choose safe adults that they would be comfortable going to for if they had a question about dating, for example. And we had them think about if they had another level of support that they needed. So if they felt that they were at risk of being victimized, or they did experience child sexual abuse or problem sexual behaviors, would they still feel comfortable going to that same safe adult, or is there someone else that they would select first to go to? We also had them identify multiple safe adults so that if one safe adult wasn't available, they had other options, and they could identify those safe adults in different contexts of their life. So safe adults at school versus safe adults at activities they're involved in versus safe adults at home. Finally, in session 8, students learn what to do in the event that they witness harmful behaviors happening to someone else. During the session, we taught students what it means to be a good upstander. So some people have heard this term, some people have not, but basically an upstander is a term that's used in a lot of bullying programs, and it refers to someone who is present at an event or an incident, but doesn't take part in the harmful behaviors, which is basically the same definition as a bystander. But an upstander also tries to help prevent the harmful behavior from taking place or gets help when needed. So they're basically a bystander who stands up for others. We teach students specific skills to stand up for others, while also stressing that first and foremost, they need to keep themselves safe. We have students practice these skills by acting out role plays. One example of that is a friend shows you another classmate's direct message to them on Snapchat. The message is a sext from your classmate. So we stress in this session as well that it's never the fault of the teen if they are unable to protect someone else from experience problem sexual behavior or child sexual abuse. And since this is the last session, we also review important materials from all of the previous sessions. And to end the program on a positive note, we provide students with the opportunity to create a mural. And the schools in our pilot study have all hung these murals up in their hallways to represent the school-wide pledge to do their best to choose responsible behaviors to keep the students themselves, younger children, and peers safe. And now I'll turn it over to Luciana to talk a bit about our pilot study of this program.
Thank you, Amanda. We conducted our pilot evaluation of RBYC in 3 main phases. In phase 1, we conducted focus groups with main stakeholders to obtain feedback on our curriculum. We heard from educators, parents, and 7th grade students. Note that in this phase, all we had was a draft of the curriculum, as we wanted to include the voices of our main stakeholders as early as possible in the process. In phase 2, we conducted what is called rapid prototyping. In this process, we presented small segments of RBYC to 7th grade health classes to receive student feedback. And in phase 3, consisted of our pilot trial with 4 middle schools, one randomized to either treatment or wait-list condition. In this phase, we also conducted interviews with educators who were present in at least one session of the RBYC implementation. I will present now each one of these phases and their corresponding findings in a little bit more detail. With our focus groups, we wanted to obtain feedback from educators, parents, and students on the acceptability of RBYC procedures and on the primary or active components of each of the 8 RBYC sessions. We conducted a total of 7 focus groups across the 3 middle schools in 2018. So this was work and we finished our trial before the pandemic. We were able to obtain feedback from 18 educators, 4 parents, and 10 students. Despite all the efforts of our research team, we were only able to recruit 4 parents, being then all females. We are hopeful that in future iterations of this study, we will be able to recruit more parents, particularly with the more widespread use of online platforms. We are hopeful that we can reduce some of the barriers for parent participation in focus groups. This slide shows main findings of each stakeholder group. Findings from our focus groups with educators show that overall, the RBYC program was well accepted. They expressed a lot of enthusiasm for our program. Educators also highlighted the importance of building rapport with the students and making them feel comfortable with the program objective before introducing any sensitive topic. Educators also mentioned that most 6th and 7th grade students would not understand some of the legal terms used in RBYC. They also stressed the importance of simplifying terms and using multiple examples to help students understand the concepts. And based on this feedback, we further simplified the terms used in intervention. So just as a note, the curriculum that Amanda just presented to you already incorporates the focus group feedback and the feedback from the second session from the rapid prototyping. So what focus groups gave feedback on was an earlier version, a much more raw version. For parents, they highlighted the importance of empowering students to make responsible choices. Parents highlighted the importance of building on what students already know and do well in terms of interacting with younger children, as opposed to giving students directions on what they should and should not do. And I thought this feedback was very valuable. Parents also noted several potential barriers to completing the family activities. They added that the informal nature of the family activities and inclusion of specific discussion questions could minimize barriers such as time constraints. And for our third group, our students group, they endorsed RBYC's discussion-based format with lots of activities, saying that they would participate more if the program was based on active discussion. As for the family activities, students identified several other family members they would feel more comfortable discussing these activities rather than their parents. They included aunts and uncles, grandparents, older siblings, older cousins. And when implementing the program, we made sure to encourage students to complete the activities with any older member of their family that they felt comfortable discussing these activities. In phase 2, we identified key active components of RBYC, and our interventionists delivered these discrete components to 7th grade health classes. We conducted 6 sessions, each lasting approximately 50 minutes. And these sessions were interactive. For example, based on students' feedback on session 1, we would then modify the content of session 2 and test an improved version of our certain activities. We had between 12 to 25 students in each one of these sessions. And overall, students greatly enjoyed the role plays and guided discussions, confirming that feedback that we received during the focus groups phase. They also expressed feeling uncomfortable with activities addressing problem sexual behavior and child sexual abuse, but reported that they felt this information was relevant. And just to add to this slide, I had the opportunity to serve as a note taker in some of the rapid prototyping sessions, and I could witness how invaluable this process is to actually have the opportunity to implement some of these ideas that we had on paper and see some of them working really well. Like anything we did with role plays was typically very well received. And sometimes you would just step into too much lecturing, and I could see the students sinking into their chairs. And of course, I would just make a note to revise that portion of the program. With feedback from focus groups and rapid prototype incorporated into the curriculum, we then conducted a pilot test with 6th and 7th graders in 4 urban public middle schools. We conducted what is called a randomized waitlist design. This means that students in 2 schools that were randomized to the intervention arm completed a baseline assessment, designated in this table here as assessment 1, received the RBYC curriculum, and completed assessment 2 after curriculum exposure. For those in the waitlist control, they completed both assessments 1 or baseline and 2. Then they received the RBYC intervention. And to allow for a pre-post comparison within the waitlist arm, students also completed assessment 3 after receiving the RBYC intervention. And finally, we also conducted interviews with educators who were present in classroom for the implementation of at least 1 RBYC session. The student assessments consisted of computer-based surveys. Students received tablets to record their responses and headphones if they chose to listen to a recording of the question. The student assessment consisted of about 100 items and took students an average of 30 minutes to complete it. The student assessments included demographics and also the measures on the main outcomes that we wanted to identify if RBYC had an impact. And these outcomes included measurements of knowledge about developmental difference between teens and younger children, knowledge about problem sexual behavior and child sexual abuse, sexual harassment experiences from and towards peers, self-efficacy to prevent problem sexual behavior, and self-efficacy to prevent peer sexual harassment. Even though we did not collect any data on problem sexual behavior towards younger children and peers, we still decided to conduct our assessments in a completely anonymous way. So no names or any personal identifier information was collected from our students. And then to link participants' responses between assessments, we use self-generated identification codes, which consists of a combination of letters and numbers derived from, let's say, specific letters from your first or last name, and specific digits from the student's date of birth. This table shows the demographic of our student participants. One school randomized to the intervention room was much larger than the other 3, contributing to a larger intervention versus waitlist control groups. So we can see in the intervention arm, we had 117 students completing our assessments, and in control arm, we had only 43. If you follow me in the total column, In our pilot trial, we had a little more female students as compared to male students. About half of our students self-identified their race as Black. And we had about 40% of participants from 6th grade and close to 60% of participants from 7th grade. Our findings show that relative to students in control schools, participants in the RBYC program reported significantly increased knowledge about problem sexual behavior and child sexual abuse facts, knowledge about laws addressing problem sexual behavior and child sexual abuse, and knowledge about sexual consent. We also identified that relative to students in control schools, students that participated in RBYC had an increase in perceived self-efficacy to prevent problem sexual behaviors and self-efficacy to prevent sexual harassment behaviors towards peers. So these are preliminary findings from a small pilot and then suggest that RBYC may be effective in increasing young adolescents' knowledge and intentions to avoid problem sexual behavior towards younger children and peers. And we believe that these findings warrant further testing, and I'm going to describe a little bit more about this when I talk about the next steps for our research. RBYC was presented to students by interventionists who were part of the research team. However, educators from each school were present during the delivery of RBYC curriculum. And we invited these educators to tell us what they liked about RBYC and what they would suggest changing, deleting, or adding. So 7 educators agreed to provide feedback. All 7 educators expressed strong support for the RBYC curriculum and emphasized that middle school students need more accurate information about problem sexual behavior. Several educators also mentioned the importance of 3 specific RBYC content areas, including consent, the laws in relation to problem sexual behaviors towards younger children and peers, and how to seek out a safe adult. We did not ask any formal feedback from our students after implementing RBYC. However, we had a number of students provide our interventionists with thank you notes. So here we have one, dear Marcus, thank you for everything. At first, I wasn't really excited for the class, but after you had taught the first lesson, I had enjoyed the lesson and you had made it educational while also fun. Thank you for bringing awareness to me and my class. I hope you get to teach us again sometime. And the second one really brings out the personality of the students. Dear Marcus, thank you for enlightening me in the realm of child sexual abuse and sexual harassment. I believe knowing about these things are very important, especially for others' safety and my own. Thank you for also being friendly and making lessons into skits or games. This really made the whole lesson easily accessible for a younger audience and clarified many details to me while showing me things and lessons I hadn't understood fully before. So it was, of course, always a pleasure to receive these notes. Overall, our preliminary results are encouraging, particularly in light of the nature of our pilot study, our small sample size. Given the support we received from our main stakeholders, the evidence of feasibility and promising outcomes, we submitted earlier this year a proposal for a larger randomized controlled trial that, if funded, will expand the evidence of RBYC to a more geographically diverse setting, including urban, suburban, and rural areas. Our pilot was only in an urban area. Include measures of behavioral change to determine whether RBYC is associated with reduced likelihood of adolescent of adolescent involving pre-adolescent children sexual behaviors. As you could see, we could not include behavioral outcomes in this pilot. We will also prepare for RBYC dissemination by assessing school and district level administrators' considerations for RBYC adoption and implementation. And we will also conduct a formal cost analysis. Our work with RBYC also includes adaptation for other populations, including our current adaptation for teens with intellectual and developmental disabilities that Amanda will now present to you.
Thank you, Luciana. So as Luciana said, I'm going to talk a little bit about our adaptation of RBYC for teens with intellectual and developmental disabilities. But before I get into the actual program adaptation itself, why would we want to adapt RBYC for teens with intellectual and developmental disabilities? Well, first, we've heard from many stakeholders, educators, general clinicians, researchers, that there's just a lack of prevention interventions designed for teens with intellectual or developmental differences, or IDD, that include materials that specifically address their unique needs, such as examples related to their experiences, or materials for students who need information presented in various ways and not just didactic learning. And as with neurotypical teens, most available prevention interventions for youth with IDD are focused on teaching them the 3 R's: to recognize, resist, and report their own abuse. Also, like neurotypical teens, teens with IDD should be provided with the information and skills necessary to make their own informed decisions. So this is an important part of protecting teens with disabilities from exploitation and abuse, and also helping them to form healthy and appropriate relationships while avoiding engaging in problem sexual behaviors with peers or younger children. And so as we started on this adaptation, we really wanted to be able to give these teens knowledge to make their own informed decisions. And for this project, our team received funding from the World Childhood Foundation to support the initial adaptation of the program. And this is an 18-month project. We're conducting this project again in collaboration with Dr. Elizabeth Letourneau, as well as in collaboration with Dr. Marian Alfanedo from the Center for Developmental Differences and Dr. Luther Kolb from the Center for Autism and Related Disorders. And those are both housed within the Kennedy Krieger Institute. Marian is an expert in providing training on sexual health to individuals with IDD, as well as to the professionals, educators, and caregivers who work with them. Luke is an expert in the measurement and treatment of mental health problems among teens with IDD. So phase 1 of our program adaptation project has been completed, and we are currently in phase 2. In phase 1, we reviewed the RBYC curriculum for neurotypical teens to identify any core components and content that already seem responsive to the needs of teens with IDD as they're currently written. And then we selected components that needed adaptation and content that needed to be added or taken out for relevance with this population, and worked on adapting those pieces according to best practices for teens with IDD. As I said, we're currently in phase 2, where we are kicking off recruitment with 3 stakeholder groups to conduct a series of focus groups and obtain stakeholder feedback on the structure, content, and implementation styles of the initial adaptation of RBYC. So this phase aligns very closely with the focus groups that Luciana shared that we conducted while developing our neurotypical program. The 3 stakeholder groups are teens with IDD, and we're looking at recruiting teens ages 13 to 17, as we understand that developmental differences are not just tied to age, especially with kids with intellectual and developmental disabilities. And so we wanted to really expand this age range to provide us greater inclusion and feedback from a larger range of teens. The second stakeholder group we're recruiting are parents of teens with IDD. And then the third group are educators of teens with IDD. After each focus group, we are going to take any suggested changes and apply them to the adapted program. And then when we go into the next focus group, we will present the material with those adaptations and revisions in place. This way, we can ensure that we have, one, adequately addressed the previous group's concerns, and then also see if we've created any other questions or other pieces of feedback that might arise from the changes that we made based on feedback from the previous group. We're aiming to conduct a series of 2 to 4 focus groups per each stakeholder group. After the focus groups are complete, in phase 3, we will analyze and utilize stakeholder feedback to revise the adapted version of RBYC into a final beta version that will be ready for more in-depth testing in future studies. Specifically, we're aiming to develop an adaptive version that can be incorporated in disability support services, in a variety of settings as a standalone program, or as a complement to existing health or sex education curricula. The RBYC curriculum for neurotypical teens was designed using best practices associated with positive outcomes in other prevention trials. So these are some of the things Luciana talked about, such as high use of behavioral skill practice, like role plays, continuity between sessions, and those parent-facilitated activities. So we're working to maintain these best practices while also incorporating other best practices for youth with IDD. So we did find when we were reviewing the neurotypical RBYC program that we were already utilizing some best practices for teens with IDD. And some examples of those are, we had a good structure of our sessions. So we were beginning sessions by reviewing content from the previous session and then outlining what would be covered the next day, and ending sessions by reviewing any main points from the session, as well as sharing what's coming up. We also didn't just focus in the neurotypical program on what not to do. We were very careful to make sure to not give teens the impression that they should be worried or afraid that they might engage in harmful behaviors. And so we really tried to take a positive spin on teaching knowledge and skills that would be more encouraging to encourage them to engage in appropriate or responsible behaviors. During the initial adaptation, we also identified a number of changes that needed to be made. And I'll just highlight a few of these. One of them is that in the neurotypical program, our lessons were designed for about 45 minutes in duration. And so we cut those down to 30 minutes for our adapted program to account for possibly shorter attention spans, or also to slow down the pace and do a lot more check-ins with students to make sure that they understand the content and check in for questions. We also worked to include even more modes of learning. So RBYC does incorporate a variety of learning modalities like discussions, videos, and behavioral practice, but we've been working to make sure the content in the adapted program is presented in ways that account for even more learning styles that can be inclusive of children who may not be able to express themselves verbally. And some of the ways that we've done this so far is to include more visual aids, more worksheets for practice, and we've worked to incorporate social stories throughout. And so social stories are short stories that describe each step of a social interaction, and they use person-first singular language, so they begin with I. So for example, I like to hug others. If I want to hug someone, I have to make sure they want to hug too. If I want to hug someone, I will ask, can I hug you? If they say yes, I will give them a hug. So we've created a number of these social stories that use positive language. So instead of saying something like, I am not going to yell, we reframe it to, I am going to use my low voice. And we've worked to support these social stories with images to accompany each sentence as well, to really help get those across in a variety of learning modalities. We're also increasing repetition and practice of important concepts and skills throughout the program, not just in the session where the content is introduced, but throughout each of the subsequent sessions as well. In addition, we're modifying examples to better fit common situations that teens with IDD may encounter and to allow for practice of skills, again, throughout the entire program. We have 4 take-home parent activities included in the neurotypical RBYC program, but are working to increase communication with caregivers in the adapted program. And so we are developing a take-home activity for every single session of the adapted curriculum, and they will include helpful resources such as the tips for having difficult conversations, age-appropriate sexual behaviors with special considerations for the IDD population, and creating these in such a way that we are being mindful that families have different values and beliefs around sex. And lastly, we are working to simplify some of our language and concepts. So here you can see in the 2 different tables, the neurotypical RBYC program on the left and the session topics for the current adaptation of RBYC IDD on the right. And so these session topics for the adapted program are not necessarily in the same order that they will stay in, and they could certainly change based on feedback that we receive from those 3 stakeholder groups in phase 2 of our project. The topics in orange designate ones that we have modified significantly or added to the adapted program. And just to highlight a few of the current changes, we redesigned the curriculum so that we start out with even more basic concepts like types of relationships and feelings, and then build upon those until we get to more difficult concepts like the sexual behaviors, safe adults, and consent. We also tried to simplify some of the abstract concepts like developmental differences, because that was very hard to cover with this in this adapted program. And so we instead focused on more concrete concepts such as age, types of relationships, and personal boundaries within different relationships. We added in some additional sections as well. So you'll see in the first line where we talk about types of relationships, and this is where students learn to identify and differentiate between types of relationships and identify the types of relationships that they have with younger children. In the next line, we talk about identifying feelings and ways we can tell how others feel. The third, we introduce responsible and irresponsible behaviors, and we talk about personal boundaries and consent. Then we move into talking about differences between private and public spaces, and also identifying public and private body parts as well. The next session is currently where we introduce sexual behaviors and how sexual behaviors can be responsible or irresponsible. And we discuss what to do if a safe adult turns out not to be safe, and how safe friends might be able to assist them in finding help from a safe adult if they're unable to identify one. We detail in the adapted program why others might ask for consent, to touch their private parts. So we talk about doctors during a physical exam versus a friend asking to touch a private part. And like the neurotypical RBYC program, we learn and practice ways to choose responsible behaviors and how to be a good upstander. In the neurotypical RBYC program, we do touch on responsible behaviors and technology, but in the adapted program, we designated an entire session to this topic. And we talk about how to choose responsible behaviors when using things like social media, texting, and gaming. The RBYC sessions in purple are the sessions where we currently have family activities. And in the adapted one, as we mentioned, we are working to have family activities for all of the sessions. So when we complete this project, we will have a beta version of the adapted RBYC IDD program that's ready for further rapid prototyping and rigorous evaluation in a variety of settings that serve teens with IDD. We specifically plan to evaluate the effectiveness of the curriculum and the feasibility of the curriculum in each of these settings. We would then like to eventually scale up the intervention for use in other languages and cultures. Since there are marked differences in the way materials should be presented to teens with mild to moderate IDD as compared to teens who might have severe or profound IDD, we would like to continue to revise the program to adapt it and provide additional content for use with teens who have severe and profound IDD as well. So to wrap up our presentation today, we would like to highlight that although teens initiate a large proportion of problem sexual behavior against younger children, and teens appear to be most vulnerable in engaging in these problematic behaviors around age 14, we found that teens tend to kind of grow out of these behaviors, and that providing them with knowledge and skills, we are hopeful that we can help them prevent engaging in these behaviors in the first place. There is a lack of evidence-based prevention programs aiming to prevent teens from engaging younger children in sexual behaviors. But the preliminary results of our pilot evaluation of RBYC suggest that RBYC provides 6th and 7th grade students with information, knowledge, and skills that may help keep them safe from engaging younger children in problem sexual behavior. These results are encouraging, particularly in light of our small sample size. So we hope that we will continue to see these outcomes in future, larger, rigorous evaluations, and that we can continue to also see this in our adapted RBYC program as well. Thank you.
Wow, thanks so much, Amanda and Luciana, for that presentation and speaking on the work that you all are doing and the evolution of that and what is to come. We did have a few questions come through while you were presenting, and if you have any additional questions, please pop those in the chat now so we can get to those. We had one question come up concerning a little bit more in terms of the demographics. One of our attendees asked or noted that nearly 50% of the participants self-identified as Black in that demographic slide. And if you're looking at the handout, I believe they're referencing slide 32. So they asked, is this due to the demographic of sample population of districts or other reasons?
That's a great question. So in our pilot study, the nearly 50% of participants self-identifying as Black was just due to the particular district that we were sampling from. And so what we did is we had approval to sample schools within a particular district in Maryland, and we reached out to those different districts, and then the ones that agreed to participate are sort of the ones that we sampled from.
Thank you. And we had another question come through. I think digging in a little bit more to the program and the focus as y'all work in that in the curriculum. Does the curriculum of the RBYC program address problem sexual behavior specifically toward younger siblings, so within that family unit? And then this attendee asked, or does it significantly matter what those relationships between the teen and child is, or what have you seen in your work in terms of those contexts?
In the neurotypical program, we do talk about all different types of relationships between the teens and younger children. And so siblings are discussed, friends are discussed, siblings of friends, other relatives, they're all discussed. They're not focused on specifically, like we don't give them specific directions to treat those children differently because they're a sibling. We more talk about what are some ways that you can positively and safely interact with those children, no matter what relationship they are. Now, in the current adaptation of RBYC IDD, we do get into a lot of relationships and talking about how different people, depending on their age and their relationship to you, may change how you interact with that person. I don't know if you have anything you want to add to that, Luciana.
I think you covered perfectly. I remember in the development stage of our program, I think we're even focused a little bit too much in sibling pairs, relationships, particularly when developing the empathic responding piece. And one of the feedback is that we had that it might not relate to our students, so might not have siblings. So we try to include several different types, as Amanda mentioned, of relationships.
Thank you, Amanda. Thank you, Luciana. It looks like those are all of the questions that we have that have come through. And just for a little bit more information for our attendees, a little bit more about the projects that the Moore Center Research has going on is available on their website. It's also linked on our event page, but you can also visit the link that I just popped in the chat at this time to find out a little bit more about the research that they have going on and all of the projects that they're doing, focusing on the problematic sexual behavior and the spectrum of that in youth development. Thank you both so much for your time today. And here are their information if you would like to follow up or have any additional questions for Amanda and Luciana. Thank you both for such a lovely presentation to add to our sexual behavior in children and youth series, and bringing that actual work that y'all are doing within communities and research-based, evidence-based programming that y'all are bringing to the prevention piece of this topic area. Again, this is a part of our greater sexual behavior in children and youth series. If this is one of your first times joining us, we highly recommend that you check out the Sexual Behavior in Children and Youth SBCY series homepage. There you will see a vast listing of other webinars that have focused on this topic area and within different approaches and different contexts as well, talking about technology use, multidisciplinary approach. We also did have Dr. Letourneau, who Amanda and Luciana both mentioned, join us for a webinar earlier on in this series, and you can currently watch those webinars and go to the event pages to find more about continuing education credit opportunities that the series has. Your input is also important to us. So if you are wanting to get a continuing education credit certificate or just a certificate of attendance for today's session, showing your professional development hours tracking, you will need to go to our event page. On that event page, under continuing education, you will see a purple button like the one on the screen. Once you click that, you will be taken to the evaluation, and then from the evaluation, once you have completed that, you will be taken to a listing of available continuing education credits that are being offered, which include the University of Texas at Austin Steve Hicks School of Social Work, the Commission for Case Manager Certification, and accreditations from the National Council on Family Relations. Again, we also offer that certificate of attendance for any students or anyone else that may be attending and just wanting to document your professional development hours. If you have any questions or any issues at all, please note that, especially if this is your first time doing a certificate of completion or any kind of certificate with us, those will be sent to the email that you provide, typically within 24 to 48 hours of completing. But some email providers will kick that to your spam folder. So please be sure to check there first. But if you check your spam folder and have not received that certificate, please email us at mflnfamilydevelopment@gmail.com, and we will be happy to assist you once we have confirmed that you have completed that. We will be happy to assist you in receiving that if you have any issues. And one final note, you do need to score an 80% or higher on that. So again, if you have done that process, please feel free to email us. And if you have any issues regarding your name on the certificate or any kind of issues with that, please shoot us an email, and Jason and I will be happy to help you getting your correct certificate. We also invite you to join us in upcoming March, which is Traumatic Brain Injury Awareness Month. We will actually be joined by regional education coordinators from the Traumatic Brain Injury Center of Excellence for 2 sessions that will explore the current DoD understanding of concussion, including causes, signs, and symptoms of those TBIs, as well as the impact of TBI and concussion on service member, their greater unit, their mission, as well as their families. Part 1 will be brain health, understanding military-related TBIs, and then that will be on March 17th. So we invite you to join us for that during TBI Awareness Month. And session 2, which you can find on the event page for session 1, will be focusing on the support for reintegration after a TBI. And that will focus on strategies for advocates, care coordinators, and case managers supporting those impacted by TBI within our military service community. And we also are very excited to announce our upcoming Military Family Readiness Academy, which will focus on family well-being and navigating the social justice landscape. So if you would like to stay updated as more announcements for that come up, please visit our landing page for that, and you can join the mailing list to become a part of that. And to finalize things, I am going to turn it over to Coral. And again, thank you so much, everyone who attended today's session, who's watching the archived recording, and to Luciana and Amanda for your time and wonderful presentation of your work today.
Thanks so much, Kaylin. We're going to go ahead and consider that a wrap for this for this afternoon, or perhaps this morning, depending on where you're joining us from. Thank you again for joining us today. If you'd like to go back and review or share this recording, it will be available on the event page for today's session within 1 to 2 business days. Thank you again to Family Development for hosting today's session, as well as to our speakers, and we wish you a wonderful afternoon. Take care, and we look forward to seeing you again soon.